following question today: the pharmacodynamics and safety of progesterone in assisted reproductive technology and what clinicians should know. That's my conflict of interest slide, and I'm a consultant for Basin Healthcare Global company. So the first message and my first slide will emphasize the importance of the nature choice, which is the micronized progesterone in pregnancy, but also looking at the different route of administration, which may influence the pharmacodynamics and certainly the pharmacokinetics. So progesterone is a fascinating molecule discovered by Adolf Butenandt in 1939. And what's amazing is that 4 Nobel Prizes were involved in the discovery and the use of micronized progesterone in women's health. In fact, a never-ending story, because every month we discover new effects of progesterone. And today in the Lancet, a nice publication about progesterone use in for prevention of preterm birth. And we know that preterm birth is increased risk in IVF patients. So different progestogens may differ in their hormonal activity depending on their structure. And for example, in this cartoon, you have dydrogesterone and progesterone. You have a double lysine here that you don't have in the progesterone formula. Dydrogesterone is a truncated molecule. So small structural changes in the configuration of the parent steroid progesterone molecule will induce considerable differences in the activity of the derivatives. But also the route of administration is important. If you compare micronized progesterone by different routes of administration, oral, vaginal, or intramuscular, you can see that at the steady state, the progesterone level will be totally different. But we know that the definition of luteal phase defect, and certainly that's true also for IVF cycles, is to keep your progesterone level at the steady state above this kind of cutoff magic level of 10 nanogram per ml. And that's exactly what happens when you administrate 200 milligrams vaginal capsules of progesterone twice a day. And that's the reason why most of the centers are using this regimen. Surprisingly, when you administrate progesterone by the intramuscular route of administration, you have quite higher plasma levels, blood levels, 5 to 7 times more than the physiological progesterone blood level. But at the same time, the progesterone level at the tissue level into the endometrium is quite lower, comparing with an optimal progesterone tissue level when you administrate vaginal progesterone. In this study, it was 800 milligrams a day, which is the current daily dose that we use for the time being in FET cycle. So progesterone has a unique pharmacodynamic profile related to the route of administration, the vaginal route of administration, and the molecule, and that's true for IVF cycles. And I put in red which are the major characteristics that we use for micronized progesterone to be efficient in luteal phase support. For sure, you have an endometrial secretory change, decidulation, vasodilatation, and it promotes the implantation of the trophoblast, but also it modulates the maternal immune response, and it improves the blood flow in between the uterus, the placenta, and the mother. And last but not least, progesterone has a crucial role during the implantation process because it reduces the uterine contractility, rejecting the embryo. So a lot of unique pharmacodynamic profile. But let's start now with the guidelines and the recommendation. And you know, you have this recommendation for the American Society of Reproductive Medicine, published in Fertility Sterility 2012. But we are in Europe, and so we have to move to the recommendation by the ESHRE Guideline Development Group, published in October 2019 and confirmed very recently in the Human Reproduction Open Access in May 2020 and in March 2021. So that's the guidelines where you will find a strong recommendation for vaginal progesterone, and that was confirmed in the 2 updated guidelines recently published in Human Reproduction Open Access. So from general awareness to practical experience, what did we learn from clinical trials? And we have to keep in mind also we have to balance the effectiveness and the safety in ART. So the first reference, which for sure is the gold standard, is the Cochrane review. And when you look at the comparison between vaginal injectable and oral progestogen in IVF settings, the conclusion of the Cochrane review will state that independently of the dose, the route of administration, there is insufficient evidence to recommend any one particular protocol. So then, why is vaginal progesterone still considered by most the first option? Is it due to efficacy? And looking at the efficacy, we have to revert to our pivotal studies done by the group of Paul de Vrouille and Johan Smith in Human Reproduction 92, where we were comparing the standard of care at the time, which was intramuscular progesterone, with the vaginal progesterone capsule, and there was no differences in clinical pregnancies, even if there was a statistical decrease in the miscarriage rate in the group of women taking progesterone by the vaginal route of administration. So since these first pivotal studies in 92, there were a lot of randomized controlled trials comparing progesterone vaginal capsules to placebo or to other luteal phase support. And consistently through all the studies, independing the country where the study were done, there was an optimal clinical and ongoing pregnancy rate. But I want to share with you this cartoon because you can see that most of the center were using or 600 or 800 milligrams a day vaginal progesterone capsules a day, which is apparently the current regimen. What about non-inferiority or comparative study? That was a study done by Berg, published in Human Reproduction 2012. It was a face-to-face study with about 1,000 participants in each group. And surprisingly, there was a positive HCG and a positive clinical pregnancy that was significantly higher with the vaginal capsule. Minus means that it's favoring the progesterone capsule in this case. And the equivalence of both treatments, the capsules and the gel, in terms of ongoing intrauterine pregnancy rate could not be demonstrated because the interval of confidence didn't lie entirely within the pre-specified equivalence interval of -7 and +7. So based on those study results, there were some groups trying to increase the daily dose of progesterone when applied by vaginal route of administration. And that was a nice study adding 300 milligrams of progesterone capsule oral to the crinoline gel and showing that there was a significant decrease in the miscarriage rate and more importantly, in the bleeding. So the message from this study is that if you increase the daily dose of progesterone in fresh cycle, you can decrease the bleeding and probably also decrease the miscarriage rate. Looking also at non-inferiority study, we have to take into consideration which is the endpoint and why and how is the study designed as a non-inferiority trial. And as it was mentioned by the group of Tournay in Brussels or by the group of George Griesinger when they did the Lotus 1 and the Lotus 2 study, unfortunately, those two studies were not powered to demonstrate non-inferiority on the live birth rate endpoint, which may be of greater clinical interest as it is mentioned in the abstract of those studies. What about the clinical practice around the world? And that's a nice electronic survey organized by the Worldwide IVF Organization. And you can see that consistently and from the 2009 until 2018, the last update, vaginal progesterone only as a luteal phase support increased across the years from 64% to 77%, confirmed in a very recent updated survey by the group of DiGuardo, published in Front Endocrinology 2020. So why is vaginal progesterone still considered by most the first option? Is that also probably due to safety? And interesting, when you look at all the safety data that we have for the time being with micronized progesterone, we have about more than 9,000 patients, all randomized in placebo-controlled study in pregnant women. And you can see that in all those studies, there is no increase or any adverse event like congenital malformation or cardiac heart failures in the neonates in all these randomized placebo-controlled study. When you apply progesterone by vaginal route of administration, it's quite easy to monitor your progesterone level. You have a first uterine path effect, and you reach at a steady state a plasma level, which is about 12 nanogram per ml, above this kind of cutoff, magic cutoff level of 10 nanogram per ml. However, if you administrate oral dydrogesterone, you have an intensive first pass metabolism, and the active hormone, in fact, as a luteal phase support, is the 20-alpha dihydrogesterone that you cannot measure in routine lab because you need a highly specific and caustic chromatographic assay to measure this active metabolite. And the group of Balash in the 80s was showing nicely that if you take oral dydrogesterone, there is no modification in the progesterone blood level. So no possibility to monitor progesterone blood level when you apply a dydrogesterone by the oral route of administration. That was the first publication by the group of Peter Humayden, taking into consideration the timing for the blood sampling. And you can see if you measure progesterone in the morning sampling, you will have lower dose comparing to the evening. So if you monitor your progesterone level during the cycle, you have to take into consideration the timing for the blood sampling. Interestingly, Elena Labarta was the first at the EV centers in Valencia, suggesting that you need to reach a progesterone blood level day of embryo transfer of at least 9.2 nanogram per ml to have significantly higher ongoing pregnancy rate. And this month, in Human Reproduction 2021, she confirmed in the prospective cohort study that women with a serum progesterone level which is below about the 9 nanogram per ml, which is the percentile 30s, there was a significantly lower ongoing pregnancy rate. So we have to be above this kind of magic cutoff level of about 10 nanogram per ml to optimize our cycle. And Elena Labarta and the EV Center are suggesting that monitoring progesterone levels in the mid-luteal phase is recommended when using micronized progesterone to adjust the doses according to the needs of the patients. And that was also suggested by the group of Cédrin and Durnerin, that you can measure progesterone and adapt your progesterone luteal phase support in function of the blood levels, but that will be addressed by the next speaker, Dominique de Ziegler. However, we have to take into consideration that if you increase your vaginal progesterone application from 900 milligram to 1,200 milligram, despite not having different progesterone blood level, you can increase the ongoing pregnancy rate. So there is no individual correlation each time in between progesterone blood level and clinical efficacy. That's a nice table published by Elena Labarta in the most recent publication in the YBEOG journal last October, summarizing all the evidence that we have using luteal phase support in natural cycle. And it's quite controversial, but most of the studies are showing that it makes sense to give luteal phase support in natural cycle, but the daily dose is probably lower as comparing to stimulated cycle or artificial cycle. So in conclusion, we have all the biological plausibility to understand why should vaginal progesterone be the first choice in luteal phase support. We have optimal endometrial impregnation, it's user-friendly, it's extensively used in fresh, not only, but also in frozen cycle. We have a lot of clinical evidence based upon live birth rate endpoint, and you avoid all the side effects or irritation related to the gastrointestinal tract after oral use. I thank you for your attention and happy to answer